So there is potassium excretion obviously because aldosterone will lead to potassium excretion, but there is no hypervolemia because the volume of urine absorbed does not change because angiotensin is not stimulated. So there is no actual volume absorption from the proximal tubule, which is the site where two-thirds of the water is actually absorbed. So that is why this is called aldosterone paradox. Okay. What you were explaining was aldosterone escape, but this is hopefully helpful. Okay. And okay, so now the next question goes to Shivam Singh. Okay, are you available, Shivam?
Yes, sir. Yes,
Ready?
sir.
Okay, so your time will start after I finish reading the question. The histopathology of ulcers caused by two related Salmonella enterica, namely Salmonella enterica serovar typhi and Salmonella enterica serovar enteritidis, was observed, and it was seen that the inflammatory infiltrate in the former case was mononuclear, while it was neutrophilic in the latter case. Why do you think this difference exists? Time starts now.
So I think because Salmonella typhi is causing the human infection, the chronic typhoid carrier, so lymphocytes should be recruited. But in the later case, it is non-typhoidal Salmonella, that is
Mm-hmm.
from the transmitted from the animals and all. So it causes acute illness, so neutrophilic.
No, you're actually explaining what is actually the manifestation, but what is the reason behind it?
45 seconds is up.
Okay, next it passes to Biki Datta. 15 seconds.
Is it because of the Salmonella typhi reside inside the macrophage, whereas the enteritis doesn't?
Mm, no,
Intracellular mechanism.
no. Okay, so the reason actually is that salmon. So in it's a gram-negative bacteria. So it has the lipoprotein, the LP lipopeptide layer in its cell wall. So it should obviously attract cells by TLR4, and it has flagella. So it should attract neutrophils by TLR5. So it should actually have a neutrophilic infiltrate, which is the case with enteritidis. But typhi has one thing extra, and that is VI antigen. And the VI antigen actually acts as a capsular covering to over the lipoprotein antigen and over the flagellin also. So it is not actually exposed to the neutrophils, and therefore they do not come in. So the response actually takes longer to appear by the mononuclear cells when it infects the M cells and it's taken up by the macrophages, and so after that it's appears. So that is why the it is an acute illness for enteritis. Longer incubation period for typhi because it takes time for the inflammation to occur. It's actually because of VI antigen. Okay, so no one gets any marks in this, and now the last question is for Vicky. So his time will start after I finish reading the question. So, a woman aged 70 years with a 5-year history of hypertension who has required progressively more medication because of persistent high BP. She is taking 5 medications, including a diuretic, but still has a BP of 165 over 95. The patient is asymptomatic and a physical exam was normal. The patient's serum potassium levels have ranged from 3.2 to 3.5 milliequivalent per liter for many years, despite potassium supplementation, which had been attributed to a diuretic use. Her renal function is normal. Why is she not responding to antihypertensive therapy? Explain the underlying mechanism, and I'll be very clear. She does not have Conn syndrome, she does not have hyperaldosteronism. Her potassium levels are low because of the drug, because of an diuretic. So now I'm asking, why is she still not responding to antihypertensive therapy? Time starts now. I just want to know, how is hypokalemia leading to refractory hypertension? The mechanism.
Sorry, sir.
Time,
I
sir.
can't answer.
Okay, passes to Soumya Bera. 15 seconds.
Sir, is it due to the diuretic use? The diuretic use causes loss of potassium. That's why the later
Yeah.
renal tubules will reabsorb more sodium, and that will lead to hypertension. Sir, I'm just thinking like that.
You are okay with the hypokalemia, but that is not how it actually happens. But okay. So this question I put to actually tell you that hypokalemia can actually lead to suboptimal blood pressure control in these patients. So what happens is when there is hypokalemia, there is actually activation of the thiazide sensitive sodium chloride co-transporters via again the WNK pathway. And when that happens, so there is more absorption of sodium, and along with that water also will get absorbed. So there is suboptimal BP control. So it is important that in patients who are taking thiazides, the potassium should be supplemented properly and that they do not have hypokalemia. So this is the mechanism. So okay, and now the last question is again like an audience question, and you guys can also try attempting it. So the question is: procainamide is used to unmask the ECG changes in a patient of Brugada syndrome, while quinidine is used for its management, even though both are class 1A antiarrhythmic agents. So why is this difference? And anyone explain why? First, can anyone tell me what is the mutation in Brugada syndrome?
SCN5.
SCN5. Yeah.
Yeah, very good. So it is SCN5A. So it's a sodium channel mutation, and that is why sodium channel blocking agent like procainamide should actually unmask the changes. But so should quinidine because it is also the same class drug. So why do you think there is a difference? Does anyone know that other than SCN5A, which channel is actually more active in Brugada syndrome, which is actually
Calcium.
no. Calcium
Potassium
is
channel.
another channel. Yeah, which potassium channel?
It's KCN5A. No,
Um,
no.
it's actually I don't know the gene name, but it's actually like the ITO channels, the transiently outward potassium channels. And because and as you know, the ST elevation which is seen in Brugada pattern is actually in the right ventricular leads, V1 to V3. So V1 and V2 are the right ventricular leads. So in that it is seen. So what happens is that there is increased expression of ITO channels in the RVOT epicardium. So what happens is because there is increased activity of ITO. Can anyone tell me for which phase of action potential is ITO responsible in the cardiac cells?
Is it phase 2?
No, it's actually phase
Four.
one. Phase two is the IKR and the IKS channels, but ITO is responsible for the dip in the phase one. So when there is increased activity of ITO channels and less activity of SCN5A, the action potential duration is reduced, and that is seen more in the epicardium, but not in the endocardium. So there is heterogeneity which occurs between the epi and the endocardium, which produces a substrate for re-entry, and that is seen in phase 2. So what happens is quinidine blocks the ITO channels. So quinidine is a class 1A drug because it blocks both potassium and sodium channels, and the potassium channels it blocks are all IKR, IKS and ITO channels. Because it blocks ITO, so it can be used for its treatment. Procainamide on the other hand blocks sodium plus only IKR channels, not IKS and not ITO. So that is a procainamide is actually used as a procainamide challenge test to reveal the Brugada pattern in patients who do not have it very evident on the ECG. So that is the reason. Okay. So can we have the scores after round two?
Sir, in round two, chess number one have 0 points, chess number two zero,
Okay.
and chess number
Mm-hmm.
three having 5 points, chess number
Okay.
five zero. Total score,
Okay. Mm-hmm.
we need to say
No, it's
total.
okay. We'll say after the next round. Okay.
Okay.
Okay, so now the next round is a systems round. So in this, you will get to choose your system. These are systems, and now we will start with Karthikeyan. Sorry, yeah, Karthikeyan will get to choose which system he wants to try, and then we'll go for each person. And again, let me tell you the scoring first. The So the scoring would be in this round would be like 20 points, and you would get again a 45 seconds after I finish reading the question to answer, and there is no pass in this round. Okay, so you will get 45 seconds to answer because everyone gets to choose their own system, so no pass. But so you will get 45 seconds to answer after it is finished reading, and there are 20 points per question. Okay. So yes, Karthik, in which system do you want to choose?
Hmm. I think I'll go with endocrinology.
Okay. So a 55-year-old man experiences episodes of diaphoresis, dyspnea, and diarrhea for 10 months. The patient has also complained of abdominal discomfort in the umbilical region and underwent endoscopy. There are no abnormal findings with upper endoscopy. A CT scan of the abdomen was performed, which is shown below, and camera endoscopy is performed, and on the review of the images, there is a mid-jejunal mass that arises from the wall and leads to multiple episodes of subacute intestinal obstruction. At laparotomy, a 5 centimeter submucosal mass is resected, and on microscopy, it is composed of nests and trabeculae of round cells with pink granular cytoplasm. So this is the CT scan. So I want what is the diagnosis and what is the cardiac lesion you expect to find in this case for 20 points, 10 points each. If you want to see the previous slide, let me know.
Uh, s- Sir, your slide itself is gone.
Is it
Hello?
is it is it can you see it now?
No, sir, I can see. Now I can see it. Yes.
Yeah. Very good. Yeah. Yeah. Yeah.
So this is a case of carcinoid
Yeah.
disease,
And what is the lesion of on the heart that you expect to see?
and so in the cardiac, any carcinoid tumor will have nesting type of pattern in histopathology, and
Yeah.
on cardiac lesions there will be collar butted collar stud lesions will be seen. Like all those
No, no.
carcinoid
I mean,
tumors.
what is like the clinically what cardiac finding would you get? Like valvular lesion.
Tricuspid regurgitation, or it will be a pulmonary
Yeah.
regurgitation kind of presentation, sir.
Okay, I'll give it to you. Okay, 20 points. It's actually tips like tricuspid insufficiency, pulmonary stenosis, but you're right. It can be like either. So either, but like it's in tricuspid valve insufficiency is more common, while in pulmonary stenosis is more common. But okay, I'll grant it to you. So 20 points to
Yes.
Karthikeyan. Okay, so next is Shivam gets to choose now.
Sir, I would like to take CVS.
Okay, CVS for Shivam. Okay. So, an 84-year-old woman is seen by her primary care physician for evaluation of severe headaches. She noted these several weeks ago and they have been getting worse. Although she has not had any visual aura, she is concerned that she has been intermittently losing vision in her left eye for the last few days. She denies new weakness or numbness, but she does report jaw pain with eating. Her past medical history includes CAD requiring a bypass grafting 10 years ago, diabetes, hyperlipidemia, and mild depression. Full review of symptoms is notable for night sweats and mild low back pain, particularly prominent in the morning. What is the diagnosis? Time starts
It
now.
is giant cell
Very
arteritis.
good. Correct. Correct. 20 points to Shivam. Good. Okay. So now we go back. Now next question is for Biki Datta. Which one do you want to choose, Biki?
Neurology.
Neurology for Biki. Okay. So, a 43-year-old white female presented to the hospital with pain in the left eye and left upper lid ptosis. She did not perceive any difference in perspiration between the two halves of her face. She was a non smoker and denied any history of head or neck trauma or ocular, cardiac, vascular, or neurologic disease. Neuro-ophthalmological examination was normal except for 1 mm of left upper eyelid ptosis, meiosis, and mild ophthalmos. There was no carotid dynia or carotid bruit, and a chest radiograph is shown. This is a chest X-ray. I want the diagnosis and what is the possible site of lesion in this case, which is causing the symptom. The time starts now. Tell me if you want to see the previous slide.
Is it Horner syndrome?
Okay, diagnosis is correct. 10 points. And where is the lesion?
Left upper lobe.
No. It's, and again say if you want to read this, you should read it again. The chest X-ray is here in front of you. You want to read the
Previous slide.
question? Yeah.
Along the
The
carotid
hint.
vessel.
Which one? Okay, you're close. Which carotid vessel?
Intern carotid.
Okay, correct. Okay. So your answer is correct. So 20 points. So this is actually painful Horner syndrome. The patient had pain in the left eye, which is usually not seen, but it may be seen when the fibers, which are the sympathetic fibers along the internal carotid artery, which are affected. It is actually internal carotid artery dissection, which can lead to a painful Horner syndrome. So this is the correct answer. Your answer is correct. Okay, so now I think only one person is left. Soumya is left. Yes, Soumya, which one do you want to choose now?
Sir, I wish to go with infectious disease.
Okay, so infectious disease. Okay. So a 46-year-old man has had gradually increasing abdominal distension along with decreased libido for the past 7 months.
Sir, I cannot see the
Physical
slide.
examination. Okay, is it visible now?
No, sir.
Okay, wait. Is it visible now?
No, sir. No, sir.
No? Okay, wait. Let me just change my network once. Right now?
No, sir. Are
Mm,
others able to view it?
are the other people able to view it?
Now it is visible, sir.
Okay.
Yes, sir. Yes, sir.
Okay,
Now
I'll
it is
start.
visible to me
Okay,
also.
I'll start reading. So, a 46-year-old man has had gradually increasing abdominal distension along with decreased libido for the past 7 months. Physical exam reveals excessive skin pigmentation in sun exposed areas. He has an abdominal fluid wave and modest splenomegaly. Fasting serum laboratory findings include glucose 200 milligram per deciliter, creatinine 0.8, ferritin is increased 650 nanogram per ml, total protein is 6.3, and albumin is 2.2. His total bilirubin, AST, ALT, and ALP values are normal. HB is 13.5, hematocrit 40.6%, and MCV is 94. Platelet count is 2 lakhs. WBC count 6570. His PT is 20 seconds and PTT is 65 seconds. So this is his baseline history. And now the patient presents with fever, chills, bloody diarrhea, and right lower quadrant abdominal pain. His abdominal CT scan is shown. So I want to know what is the diagnosis. So this first part is for 10 points. Why was this person predisposed to this condition for 5 points? And selective medium for the organism implicated for 5 points. The time starts now. Tell me when to switch between slides.
Yes, sir. Sir, is it pseudoappendicitis that is caused by Yersinia?
Very good. Yes, very good. Why? First part is correct, 10 points. Second,
And selective medium is ghee agar.
which agar?
Ghee agar. We have a ghee agar.
Mm, can you spell? Okay, answer the second part.
Maybe hyperferritinemia is the risk factor that has predisposed to this person.
Why does this patient have hyperferritinemia?
No, so sir, I'm just taking a wild guess.
You are close, but why does this patient have hyperferritinemia?
Times.
Okay. So the answer it is because of hemochromatosis. This patient has hemochromatosis and Yersinia has like
Yes, sir.
siderophores. So and so 10 point in which agar did you say? I have not heard of it. I'll confirm it. Ghee agar.
Yes, sir. So there is a ghee agar that is the selective medium for the Yersinia.
Okay, let me check. If it is correct, then I'll grant the points to you. So this is actually for Yersinia pestis. That's not correct. This is actually Yersinia enterocolitica. So Yersinia enterocolitica it has CIA in agar, cephsalodin, uric acid, novobiosin agar, and it has like bullseye colony. So that the one you were saying is for pestis. So that is not correct, but you get 10 points. Okay. Okay, so now you all can just try the question which is left on immunology. So Johnny Stewart is a 4-year-old boy presenting to the hospital with hypotension, lethargy. Whose mic is unmute? Hypotension, lethargy, and hyponatremia. You also note that his potassium level is elevated to 5.7. He's afebrile and has a normal complete blood count. However, you note extensive oral thrush. On review of his chart, you note that he has had multiple treatment courses for thrush and cutaneous candidal infections. HIV antibody tests have been negative. You note that at 1 year of age, he had an episode of tetany, prompting an emergent presentation into the hospital, where he was found to be hypocalcemic. Ultimately, he was diagnosed with hypoparathyroidism. What is the diagnosis?
Said
Tyjohn.
one. One. APS one.
Yeah, very good. Yeah, very good. This is APS1. Okay. So can we have the scores after this round and the total scores, please?
Sir, after round 3, chess number 1 with 20 points and total score 37.5.
Okay.
Chess
Very
number
good.
2
Okay.
with chess number 2, 10 points in round 3 and total of 35.
Okay.
Chess number 3 with 20 points in this round and total 30 points.
Okay.
Chess number 5, 20 points in this round and total of 40.
Okay. Okay. Good. Okay. So now we are in like the fourth round. We, we will be like starting this round with Shivam, and yeah. So now this is a mixed bag. So this will have different type of questions. These are slightly more difficult questions, but if you get it right, then you get 30 points. Okay. And there is pass, but some questions do have part points, so the part point would be like halved if it is passed to the next person. Okay. But again, in this round, the catch is that if the diagnosis is answered, then the question won't be passed. Okay. If diagnosis is not answered, or if it's a connect question, then the things will go in the same way. Like if like one question in the connect question, only the 10 points are for the connect, and only those 10 points will be passed to the next person. Okay. The each image score is increased to 5 now instead of 2.5, so that will not be passed. And if the diagnosis is answered correctly, then the question won't be passed forward. Okay. So we are starting, and now the first question will go to Shivam. Okay, are you ready, Shivam? Okay. So a 28-year-old man presented with a complaint of gradual visual loss during the past 5 years. He had noticed night vision difficulty since the age of 15 years, but did not seek medical advice. His visual acuity in each eye was at the level of counting fingers. His refractive error measured for -6 for the right eye and -5 for the left eye. His best corrected visual acuity was 3 by 10 in the right eye and 1 by 10 in the left eye. Bilateral 2 plus posterior subcapsular cataracts were present. Fundus examination of both eyes is shown. He had mild muscle weakness, but his intelligence and his EEG findings were normal. And this is his fundus. So I want to know the diagnosis. What is this finding in the serum which will collaborate with this finding? And treatment. Three things. Time starts now.
Sir, is the diagnosis guided atrophy,
Very
delta
good.
ornithine
10 points.
aminotransferase deficiency?
Okay, what is the serum finding?
Since delta ornithine aminotransferase is defective, the ornithine
Hmm.
will be raised, and
Okay, correct. Yeah, and treatment?
treatment is vitamin B6.
Okay, correct. And okay, correct. So 30 points to Shivam. Correct. So diagnosis is gyrate atrophy. It presents with hyperornithemia, and treatment is pyridoxine therapy and arginine restriction and diet. Okay, very good. So he gets 30 points. Okay. Now the next question is for Vicky. Are you ready, Vicky?
Yes, sir.
Okay. So, an 11-year-old female patient with a prior history of cardiac arrest arrived at the emergency room 35 minutes after losing consciousness. There was no specific family history of syncope or sudden cardiac death. 6 years ago, she experienced a brief syncopal episode, and 6 months after the first event, she was admitted to the ER for sudden loss of consciousness. VF was noted and normal sinus rhythm was restored by defibrillation. EEG, MRI of brain and resting ECG were normal, and echo did not reveal any structural abnormalities, and Holter did not reveal specific arrhythmias. Patient was put on atenolol to prevent future arrhythmias. Upon this ER arrival, the patient was unconscious, pulseless, and without spontaneous respirations. BP was undetectable and her body temperature was 36.5. The initial ECG showed VF. NSR was restored after two monophasic direct current fibrillations at 200 joules. Serum electrolytes were normal and the patient was diagnosed with catecholaminergic polymorphic ventricular tachycardia accompanied by typical bidirectional VT, which was triggered by sinus tachycardia. So, what is the underlying genetic defect in this condition and which drug specifically counteracts this defect? 15 points for each question. Time starts now.
So is it a channelopathy?
Yeah, which channel? Yeah.
Calcium channel.
Mm, that is not the most common defect, but I want the underlying the most common defect which is seen.
Long QT.
No, which try answering the other part also.
So time is up.
Okay, pass this to Soumya. Vera, you can try.
Yes, sir. Sir, is it RYR2 CPVT with bidirectional tachycardia arrhythmia syndrome?
Yeah, what is RYR2?
Ryanodine receptor.
Okay, and which drug counteracts this defect?
Sir, is it beta blockers?
No. Okay, so he gets 7.5 points for answering one part. So correct answer is that RYR2, and the drug are like actually the class 1C drugs, flecainide and propafenone, which actually block the RYR2. So there is activating mutation in RYR2 and they can block. And so when you give flecainide is always given with a beta blocker to prevent arrhythmias. But when propafenone is given, then propafenone itself has beta blocker activity. So flecainide and propafenone can be used. So beta blocker is the first line therapy, but it is not the drug which specifically counteracts this defect because flecainide and propafenone block RYR2. Okay. Okay. So he gets 7.5 points. Okay. Now the next question is for Soumya Bera. Are you ready, Soumya?
Yes, sir.
Okay. So you have to connect this.
Sir, I cannot see the
Start.
slides again. So it is the
Is
same
it
slide
vis-
CPVT wala.
is it visible now?
No, sir.
Can you guys see my screen right now? Hello.
Sir, I can see your screen now. It is RYR2 and flickenide.
Okay. Am I audible?
Yes, sir.
Yeah. Okay. Wait. Let me just put it back. Is my screen visible now?
Yes, sir.
Okay. Okay. I'll put the slideshow back up. Okay. Okay. So Soumya, your question is here. So now can you see the images?
No, sir. It is still RYR2 and flickenide.
Now can you again? Which slide do you see now?
So the same slide RYR2 and flickenide.
Okay. 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 Uh, okay. Now do you see the question?
No, sir.
Mm,
Are others able to see it? Vicky Datta, Shivam, and Karthikeyan.
Not visible.
okay. Wait.
Not visible. It's not visible.
Okay. Okay. I'll share my screen once again and see if it works.
No, sir, same slide only. Right now.
Y- Yeah. Is my screen visible right now?
No, sir. It is minimized. I can see a smaller version of Google Meet just.
I think my network is slow. That's the problem. Hello. Is my screen visible right now?
Yes, sir. I can see the PowerPoint.
Okay. 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 Now let's try to do it again. Okay. Yeah, this is the question visible now?
Yes, sir. Question is visible.
Okay. So now, yes. So now you can. The time starts now. Start connecting the images.
So the orange tonsil wall image is Tangiers disease.
Okay. Correct.
So the first one is it ichthyosis. The harlequins
Yeah,
can
okay,
change.
correct. Yeah, correct.
Hmm.
Okay, two correct, yeah. The other
The
two?
the second one is it retinoschisis.
No,
Sir, the tigroid appearance.
no.
And the last, sir, is it metachromatic leukodystrophy?
Not metachromatic, but it's close. Try to attempt that again in the connect.
Leukodystrophy, X-linked adrenal leukodystrophy.
Yeah, correct, correct, correct. And in
So
the
the last
connect,
image is leukodystrophy, Harlequin skin change, Tangiers disease,
yeah,
and the fundus
connect.
finding. Sir, is it angioid streaks?
The finding is correct, but
Sir, time is over.
the
Pseudoxanthoma
okay,
elasticum or something like that.
yeah, correct. Okay, so you get 20 points, and now the next person's Karthik and Yash should play for the connect for 10 points, 15 seconds.
Sir, these are all defects of the ABC gene transporters, sir. Tangier is ABC
Very
gene,
good.
ichthyosis is
Correct.
AB gene, and adenoleukodystrophy.
Correct. Correct. So he gets 10 points. So they're all ABC gene mutations, ATP binding cassette, harlequinichthyosis ABCA12 mutation, pseudoxanthoma elasticum ABC6, Tangiers ABCA1, and Xlad ABCD1. So Soumya gets 20 points and Karthikeyan gets 10 points. Okay, very good. So now the next question is for Karthikeyan. Okay, Karthikeyan, are you ready?
Yes, sir.
Okay. Okay, can you see the question? This entity presents as a subacute progressive encephalopathy with myoclonus and periodic triphasic complexes on EEG and should be excluded in every case of suspected CJD. But unlike CJD, there is fluctuation in severity of illness and this responds well to glucocorticoid therapy. What is the diagnosis and what is the antibody used to diagnose this condition? The time starts now, 45 seconds.
Sir, I think uh, because of the response, is it like Hashimoto's encephalopathy, steroid responsive
Okay,
encephalopathy with autoimmune
yeah,
thyroiditis,
yeah,
SREFD
and what is
syndrome?
the and what is the antibody?
Antibody is like it mimics P-ANCA, so alpha inolase antibodies.
Very good. Okay, 30 points to Karthikeyan. Okay, so this is steroid responsive encephalopathy associated with autoimmune thyroiditis and anti-enolase antibody. Okay, so this round is over. Just the last question is just for everyone to see. So a 22-year-old male presented with complaints of weakness in all four limbs, impaired vision, urinary incontinence, and dyspnea. Previously, the patient had experienced 6 similar attacks, and the longer the attacks, the worse the symptoms got. A history of low back pain, muscle spasm, and numbness was found. Neurological examination found a weakness in all four limbs, accompanied by increased DTRs and the presence of pathological reflexes. Visual acuity was reduced in both eyes. Right eye was 1 over 300 and left eye was 1 over infinity, respectively. Fundoscopy revealed a picture of bilateral atrophic papillae, and the OCT was normal. The presence of exteroceptive disorders and proprioceptive disorders was accompanied by urinary incontinence, and blood tests and CSF analysis were within normal limits. HSV antibody, PCR analysis on HSV and CMV were negative. ANA was normal. Electrophysiological examination of somatosensory evoked potential found lesions between C2 to C7 and T2 to T7, and VEP found partial blocks of bilateral visual pathways. The spinal MRI showed a picture of myelitis involving C3 to C6 and T2 to T6. MRI brain was abnormal. So first tell me the diagnosis and the three FDA drugs, approved drugs for this condition.
NMO,
Yeah, and the drugs, there are three drugs which have been approved.
satralizumab, and inebilizumab.
Very good, correct. All three correct. So it's eculizumab, anti-C5 antibody, inebilizumab, anti-CD19 antibody, and satralizumab is anti-IL6 receptor antibody. Okay, so can we have the final scores after 4 rounds?
Okay, sir. After 4 rounds, the total score of chess number 1 is 52.5.
Okay.
Chess number 2, 62.5.
Mm-hmm.
Chess number 3, 70. And chess number 5 also 70.
Okay. So very good. You all guys like gave very good answers and played well. The quiz is not over. I think you will guys will have one more like round like this after this, and then the final scores you will get. But well played. Um, this was the last question. Yeah. Okay. And like, do you guys have any like feedbacks or?
Very good quiz, sir.
Okay.
Very much.
You
All the questions
okay?
connects
Mhm.
all the clinical list and also the trivia types. Both all mixed, sir. I enjoyed the quiz. Thank you,
Mhm.
sir.
Okay, you guys well played.
So it's a good mix of clinical questions as well as factual questions also.
Mm.
So, sir, overall, sir, it was a very great quiz.
Okay, thank you so much. Okay, okay, so thank you for having me for the first 4 rounds, and all the best for your remaining two. Like I think you'll have 2 or 3 rounds more after this. Okay,
Thank you,
all
sir.
the best. Mhm.
Thank you, sir.
Thank you, sir.
Okay.
Sir,
Yeah.
so can you hear me?
Yeah. Yeah. I can hear you.
Okay, thank you, sir. It was a very informative and interactive session. And I also congratulate all the participants. Once again, I thank you all on behalf of our college union. Thank you, sir, and all the participants.
Okay. Thank you. All the best to everyone.